That's us going live. Hello everyone, welcome to our third Mind the Bleep webinar in our FY1 Survival Guide 10-part series. Today's talk breaks down ward rounds and documentation, and it's going to be delivered by my colleague Dr. Hamza Duffaydar, who is in FY1 soon to be FY2 in the West Midlands. Just a reminder that this webinar will be recorded and uploaded to Medal and the Mind the Bleep YouTube channel. Please remember to ask questions in the chat and we'll make sure to answer them at the end. I will also be available in the chat to answer any questions throughout the webinar. Remember, you can also sign up for free weekly webinars. I'll post the link in the chat. We'll also post the link for the feedback form in the chat at the end of the webinar, for which you'll get a certificate for your portfolio. Without further ado, I'll hand over to Hamza.
Right, thank you, Nihal. Okay, let's get started. So today's talk will be on ward rounds and documentation. So welcome to today's talk on ward rounds and documentation. This will be an important part of your role as an FY1, if not the most important part. The GMC states you must keep clear, accurate, and legible records. For the majority of you, your hospitals will still use paper notes, and thus this talk will focus more on paper notes and handwritten documentation. However, some of you will also use electronic notes. This talk will also be relevant because the principles are the same. Unfortunately, medical school does not teach you how to document in patients' notes, and thus that's something we both have learned whilst on the job. Hence, we thought this talk would be really important for you guys. So today's topic will cover good documentation, how to write in senior-led ward rounds, how to do a solo ward round, jobs list, and finally a summary at the end. So why is it important to document well? Patient notes are legal documents. If there is to be an investigation into a patient's death or the quality of care they've received in hospital, the responsible body will use the handwritten notes, aka your documentation. Patients' notes also ensure continuity of care and allow the clinician responsible of this patient's care to get a good understanding of what has happened over the last few days. As you might appreciate, doctors keep changing over and over again. Hence, the patient notes are the only continuity of care that we have other than handover. For instance, the only way you can figure out what has happened over the last few days, especially if you've been off on the bank holiday, is through the patient's notes. Good documentation also helps guide the patient's care and the care delivered by other members of the healthcare professional team. For example, if your patient is due to go to surgery tomorrow and they are to be kept nil by mouth, writing nil by mouth as from midnight in the patient's notes will let the nursing staff and the HCAs know that this patient should not receive any food or drink as from midnight. Good documentation will also help you and your colleagues write discharge summaries. Instead of flicking through pages of notes, if someone has documented well, you have the most up-to-date information readily available at hand. Lastly, through good documentation, you can readily update patients and family members of the current progress. This is particularly important because you might not be familiar with this patient's care, and hence this documentation will allow you to become familiar with what has happened over the last few days. Okay, let's move on to the components of a good documentation. So here are the key components of good documentation. It should always include a date and time, and include a patient identifiable details. For those of you who use paper notes, the ward clerk will usually print some stickers with patient identifiable labels, which you can stick at the top of each continuation sheet. And for those of you using electronic notes, this is automatically done, so you don't need to worry about this part. You'll also have to write the name and the role of the assessing person at the top, and usually write this in bold letters. So then you write the plan and the examination, and then when you finish, you write your name, you sign it off with your GMC registration number and a signature. Again, for those of you using electronic notes, this will automatically be done, But for those of you using paper notes, you can use your fancy stamps, which will be provided by your hospital. So patient notes should be legible, and it should also be in black ink. It's preferable to use ball pen. Remember to be courteous in your documentation. This is because most doctors will have read your documentation before having read you, and thus they would have formed an opinion of you based on your documentation. So here are two examples of documentation. Again, these are made-up scenarios. So you have the patient identifiable details at the top, the patient's name and the hospital number, the date and time, the assessing person. So this is myself. If it is yourself, you can write the initial of your first name, followed by your surname and your title, so FY1, and what you were doing at that time. So you might have been on call. And it's good to write it in bold as well. So then here you can document. It should be legible in black ink, and then always include a plan for the nursing staff and other members of the healthcare team so that they're familiar with what's happening as well. I've also included my stamp, which has my name, my GMC registration number, and a signature as well. So this is one instance where I've documented about an NG tube location to start patient feeding. So you can see if anything goes wrong, they can go back to this documentation and see who it was who documented that. On the right, you have another example of a documentation I've written for a patient who's had a fall and they were on a DOAC. So I've written the reports of the scan as well, which I've been asked to chase. And I've written a clear plan. So start on the DOAC again and continue neuro observations. So this is how you guys should aim to document. So now we're going to go on about senior-led ward rounds. So for senior-led ward rounds, have a patient list prepared. Seniors will rely on FY1s to direct them as to which patient they need to see. That's easy if you're on a specialized ward such as cardiology, because all your patients will need to be seen anyway. But if you are on other specialties, you might have patients all over the place, all across the hospitals, on different wards, and you'll also have outliers. So it's important to know who your patients are and where they are. The last thing you want is for you to having missed patients during ward round and then being called to see them near the end of your shift. So having a good patient list will ensure that you know where to go. Know the name and role of your seniors, and so that you can also document this whilst writing, and have the observations of each patient ready. So most trusts will use the News to score. So then you can readily have this available through the computer or through the paper News to chart. And if patients are scoring, know for what they're scoring. Have blood tests also available and the trend of these blood tests. So blood tests in isolation mean nothing, but if you have a trend to compare with, it can give you a better picture of what's happening. You can also include relevant medications, such as antibiotics, but only if it's relevant. For example, if a patient's on day 3 out of a 5-day course of antibiotics, that would be relevant, so you can write this down. And you can also document the results of any scans and procedures. So all of this that we've mentioned so far, you can have this ready before going to see the patient by their bedside. As you can see, before going to see the patient by their bedside, you already have a lot of information about this patient, and you can start to form a picture about them. When you go to see the patient by their bedside, you can document like any concerns the patient has or how they're feeling. Usually if the patient's well, I will write patient comfortable at rest, and then if there are no concerns, write no concerns at present. You can also document the results of relevant examination findings. And because this is a senior-led ward round, your seniors will usually direct you as what to write. For example, if they're examining the heart, they'll tell you to write the results of their auscultation. So heart sounds, a murmur heard, a murmur not heard, or chest clear. And lastly, at the end of your documentation, it's really important to include the plan. So have a plan listed, including the jobs that need to be done and the current management that needs to be followed. If you're not sure about the plan, again, ask your senior members before moving on to the next patient. So this is again an example of another ward round entry. Again, this is a made-up scenario. So on the top right, you can see the patient's name and the hospital number. On the left, you can see the date and the time. So the time is usually the time at which you see the patient, not the time at which you've prepared the notes. On the left, I also have the observation, so the new score, and for what the patient is scoring, so their oxygen sats, and they're on 2 liters nasal spect, their heart rate, blood pressure, temperature, and their weight. Their weight is only relevant in certain situations, such as cardiology, where you have patients overloaded. So usually the weight is important because we do daily weights to monitor the progress of the offloading. So then it's important to have these observations at hand. And if my senior does ask me, what is the patient scoring for? I can remember and say they're scoring for 93% oxygen saturations on 2 liters of nasal spect. On the right, I usually write the blood test and the date at which these bloods were done. So I've written the HB and only the relevant blood test. So white cell count, as you can see, is raised. Neutrophil is raised as well, and so is CRP. Usually one trick I do, I put a little star next to it if it's abnormal. The computer system will tell you if it's abnormal, but that's just for documentation purposes. I put a little star so I can remember as well. And you can see as well, I've written next to it. So the first set of results I've written are the blood tests that were done on the 5th. And on the right are the previous readings for the same parameter. So you can see the trend. The white cell count is actually going down, and I've written a little arrow. Neutrophil count is going down, CRP is going down, and EGFR is going up. If things are normal and they're not relevant, I usually just abbreviate it to normal LFTs or bone profile or normal user-needs. You can also include information about relevant culture, so such as sputum culture or urine culture. For this patient, for instance, Joe Bloggs, you can see urine culture was positive for E. coli on the 2nd of June, and it was sensitive to trimethoprim. On the top, I usually write the patient's name and include a little symbol for male or female. Have a background of this patient as well, so their past medical history, but only relevant past medical history. So Joe Bloggs has a history of heart failure, type 2 diabetes, and osteoarthritis. And I also include a little bit about the presenting complaint. So Joe Bloggs came in with 2-week history of worsening shortness of breath and ankle swelling. Below that, I've put a little triangle. The little triangle sign is for the diagnosis of this patient. So the diagnosis is CCF, congestive cardiac failure. They've also had a UTI, as you can see from the urine MCNS during this admission. And they've also had an AKI, but this has resolved now. So it's not reflected on the EGFR. I've written a little note about the patient's offloading on 40 milligrams of IV furosemide BD. So that's where I've said only include medications if it's relevant. And on a day 3 out of a 7-day course of trimethoprim for their UTI. Below, I've written the results of scans. So his chest X-ray was clear. And the results of his echo, because this is relevant as he has cardiac failure. So severely reduced left ventricular ejection fraction and left ventricular ejection fraction less than 40% with no valvular pathology. So all of these bits have been prepared before actually going to see the patient. As you can appreciate, you already have a clear picture of the patient and what's going on before you've even gone to the bedside. So that's why good documentation is good. Below, I've written about the examination, so that's when we do go by the bedside. The patient is comfortable at rest with no new concerns. The senior clinician has listened to their chest, and their chest was clear. There is some mild evidence of pitting edema, so I've done a little drawing. So usually for your examination, there are some drawings and symbols you can learn. For the chest, you can draw 2 lungs, and then if clear, you can cross it out. If there are crackles, you can just draw little crosses at the lung bases. For heart sounds, it's usually recorded as 1 + 2 + 0. 0 means there are no murmurs, but if there are any murmurs, you can write 1 + 2 + systolic or diastolic murmur heard. Abdomen, soft and non-tender. I've drawn a little hexagon, I think. Yeah, a little hexagon, and then crossed it out. So that means the abdomen is soft and non-tender, so no relevant findings there. And then for the calves, I've drawn like 2 little legs. Again, an important part of the documentation is the plan. in the plan I've written continue offloading daily weights. So that's for the nursing staff to be aware that we should measure this patient's weights every day, and bloods every other day. So this is relevant for myself and for my other colleagues because I might not be in work over the next 2 days. So my colleagues can always go back to my documentation and know when we wanted bloods taken for this patient. I've also written continuing antibiotics for UTI, so my colleagues know that we should not stop the antibiotics presently. And I've written a plan in anticipation. If this patient does have further temperature spikes, we'll do blood cultures and speak to microbiology regarding the antibiotics. Below, I've also written a job for myself, just to remind myself, so to chase this patient's notes from another hospital from a previous admission. And discharge planning. So discharge planning is for the nursing notes, for the nursing staff to know. The nursing staff will usually go through your documentation to know what needs to be done for this patient. That's why it's really important for your documentation to be legible and to have a clear plan for them. And then lastly, I've included my stamp with my name and GMC registration number, and I've signed for it as well. It's really important to have your jobs written in the plan. I mean, you will go around with a jobs list as well, but the main source, the primary source where you should write your jobs should be in the plan. You can always come back and update your jobs list, but we'll talk about jobs list a bit later on. So here are common abbreviations that could be used. I've taken this from the Mind the Bleep page. They have an article on ward rounds and documentation, so I recommend you guys having a quick look about this as well. So if we're writing days, if it's in less than a week, we write it out of 7. If we're writing it in terms of weeks, it's out of 52 because there are 52 weeks in a year. And in month, it's out of 12 because there are 12 months in a year. Some common abbreviations are HR for heart rate, RR for respiratory rate, MFFT, medically fit for discharge, PT and OT, physiotherapy and occupational therapy, TWOC, trial without catheter. So that's when you try, when a patient's been catheterized, you remove the catheter and you see if they can pass urine without that catheter. FU is follow-up in clinic. POC is package of care. So package of care is usually when we send patients home with like carers and everything for that. So these are common abbreviations. Again, don't be too overwhelmed that there are so many abbreviations. You will get used to this as you start on the job. But you can familiarize yourself with some of these abbreviations using this presentation or the Mind the Bleep article available on the website. So solo ward rounds. It's important to prepare well for solo ward rounds. So by good preparation, I mean prep the notes well, having the observation and the blood tests at hand, knowing about the patient's background, their age, and their presenting complaint. You can also update patients about their blood tests or any scan results. You might not appreciate, but a lot of patients are not aware of their management plan whilst in hospital, because a lot of doctors actually go around forgetting to update patients of what's happening. So patients really appreciate that. When doing solo ward rounds, this could be a good opportunity to update patients about what's happening. Again, if there is like breaking bad news, this is probably left to senior members, but little things such as improvement in inflammatory markers or chest x-ray showing X finding, you can update patients about this. When doing solo ward rounds, it's important to familiarize yourself with the previous plan that was written in the previous ward round done by a senior member of staff and the current management plan. So usually your consultants or regs will only let you do solo ward rounds if they think the patient will continue on the same management plan which they've directed over the last few days. So that's why it's really important to go through their last entries. But that having been said, when doing a solo ward round, it's important to be thorough. So do a quick systemic examination, check if the symptoms of the patients are improving, if they're opening their bowels, if they're mobilizing, and if there are any concerns, discuss with your seniors. So have a low threshold to escalate during solo ward rounds. The support is always available in your hospitals, in your trust, and it's better to escalate rather than not. So you can discuss with your seniors, and it doesn't necessarily mean you have to escalate for every patient. You can just have a brief conversation and run your plans past your seniors just to see if they agree with your plan. But if there are any like red flag symptoms, you have to escalate to your seniors. So now we go on to the jobs list. So the jobs list is an important piece of document for each F1 doctor. You can use this as your patients list as well. So this is an example of a format of a jobs list. You each will have your own style of doing it and your personal way of writing down your jobs list. But here's an example you can follow. So in the first column, you have the patient's location, their bay and their bed number. So you can use this as a patient's list as well to direct your seniors or to know where your patients are. You have the patient's name and you have their diagnosis as well. You have any ongoing issues. So you're familiar with what's being done for this patient. And then on the right, you write any jobs that need to be done for this patient. Again, I must emphasize that it's more important to write the jobs in the patient's plan first and then write it in your jobs list after. As you might appreciate, ward rounds are done really quickly. So you can always come back to the plan in the documentation and update your jobs list. The reason I say that is because your jobs list contains patient identifiable information. So you will usually throw the jobs list, or you should throw the jobs list away at the end of each shift. So if you're not in on the following day, the only way your colleagues taking over this patient's care would know whether a job is done or not is by checking the patient's plan or documentation, because they won't have your jobs list. So after the ward round, you can regroup with your colleagues and to go through the jobs list. You can update your jobs list, or you can go back to the notes as well to make sure you have an up-to-date jobs list, and then divide and conquer. You won't be alone. You'll have other colleagues. So brainstorm and then see which colleagues will do which jobs. And communication is really important because you throughout the day, you'll know which jobs have been done, and this will save you having done the jobs twice. So below is a little image of what most junior doctors have done in the past. I mean, you can choose to use this or not, but most people have found it useful. Usually, if you draw a little square next to your job, and if it's empty, it means the job is still outstanding. If you have a line across it, it means the job has been requested, such as a scan, a radiological scan, but it hasn't happened yet. And if you half shade the box, it means the job is half done. For example, you've taken bloods for this patient, but you're still awaiting results from the labs. So the job is not completely done because you still have to chase the blood results. And if the box is completely filled in, that means the job is completed. So to summarize, we've talked about the importance of good documentation, how to document. We've talked about ward round entries for both senior-led and solo ward rounds, and the importance of a jobs list. If you've liked this talk, feel free to tune in for our other talks of our FY1 Survival Guide. So we'll have a range of talks covering the contract and managing deteriorating patients as well. We'll have speakers from different backgrounds, including medical registrars or accountants as well, who will speak about the relevant topics. So this might be quite useful for you. So this is the end of my presentation. It's been quite brief because I appreciate that most of it will be through questions you guys might have, which we'll answer at the end. So this is a barcode. If you scan this, this will provide you feedback forms, which you can use for your portfolio. You can count towards your non-core teaching hours. So we're happy to answer any questions you guys might have. So put the questions in the chat and then we'll just answer them.
Thank you very much for that talk, Hamza. Your documentation is certainly a lot better than mine.
Thanks.
Guys, before we start answering any questions, I'll just let you guys know about our free Prepare for FY1 course. So these are identical in-person courses based in Liverpool, London and Sheffield. They're simulation-based with 5 years of experience. Free lunch and dinner is provided thanks to our sponsor, The Next Step. Last year, confidence for FY1 rose from 19.6% to 74%. And there's a next step Q&A panel with expert junior doctors. So guys, because teaching is in small groups, it's quite in demand. We're almost sold out. So for more details and to sign up, go to mindthebleep.com/FY1 course. And now, guys, you can put any questions you want in the chat and we'll start answering them. Yeah, I'll post a link for the feedback form. Any questions, guys?
Any tips for people with really terrible handwriting? I don't know. I guess it depends. If you're going to somewhere where they have electronic notes, then you don't really need to worry about that because you'll be typing. But if not, I guess just take your time. Ward runs will feel quite rushed. So even some of us who have really nice handwriting, our handwriting will not be the best because ward runs are quite rushed. So take your time. You can always come back after the ward run to write it again. But as long as you have something there to remind you, you can come back after the ward run to write it, take all your time and write it legibly. Do you have anything else to add about this, Nihal?
No, I think you've covered that quite nicely. A question from Sharon John. How do you know who is the senior you're doing a ward round for?
So they'll usually come at the start and they'll introduce themselves to you, and you will be working with a team. So you'll be with this team for 4 months, so you'll become quite familiar with them. But on the first day, you'll usually introduce themselves to you. They'll come find you. Um, I want to say through their badge, but most seniors don't actually wear their badge. But they'll come and find you. So I wouldn't worry too much about it. And then over the next few days, you'll just get to know who they are.
Just a question from Craig Start, which I'll answer. So Craig's asked, any chance of an FY1 course happening in Scotland or just England? So we're not actually organising the course. It's through Mind the Bleep. From what I understand, because of the capacity of the junior doctor panel, they've only been able to arrange it in London, Liverpool and Sheffield. So at the moment, nothing for Scotland. I can raise this with them though, and we'll, if there's any updates, we'll update them on the Bleep Facebook page for you guys. Okay. For a question from Khalid Taha, so Hamza, any tips for new graduated students in a forced clinical gap?
Newly graduated forced
So
clinical.
I think Khalid means actually I'm not quite sure. Khalid, can you just expand on that, and we'll answer that in a second. Hamza, a question from Daniel Nee. Is SOAP a legitimate framework of making ward round notes?
So I'm not personally familiar with the SOAP framework, but as long as you have a good way of documenting, it should be all right. Yeah. So I'm
I
not
think I've
personally.
heard of SOAP in medical school. I think it is a legitimate framework for making ward round notes. The main thing is that you're writing clear, legible. Like Hamza said, you've looked at the observations, the bloods, the trending of the bloods. You've written down a problems list. You've assessed the patient. So, how are they doing today? You've examined the patient and you've put a clear plan. So, I think SOAP does include that. Everyone has their different methods. So, if you like SOAP, go ahead and use that.
So Rachel has asked, is documentation and ward rounds similar for weekends? Any tips for prepping notes or requests for the weekend? So yeah, documentation and ward round will be the same for weekends. It'll be the same for weekends, for night shift as well. Obviously, there won't be any ward rounds during the night, but like you'll always be called on the wards to document. So it'll always be the same, and get in the habit of having a um, good documentation habit, good way of documenting, and then it will just become second habit for you. Any tips for prepping notes or requests for the weekend? So it would be the same. Yeah.
Hamza, just a question from Oladapo. Can you apply these features to surgical ward rounds, and how are surgical ward rounds different from medical ward rounds?
Yeah, absolutely. So the reason why I didn't divide it into medical and surgical ward runs is because the same principles apply. Again, you will you'll have the date, the time, your observations, your blood tests. So it's exactly the same. The only thing during surgical ward runs is surgical ward runs are quite quick. So you might omit quite a lot of the information. So for instance, for observations, like in the example I gave earlier, if the patient was using a tool, in a surgical ward run, I would only write what they're scoring for. Um, I wouldn't really have time for the background because this wouldn't really be relevant. So in surgical ward runs, it's a bit less documentation, but also always include the relevant findings, the relevant information. Yeah. So the example I gave you and medical ward round documentations are gold standard, but then in surgical ward round, because they go quite quick, uh, they don't include all of it. And again, your examination for surgical ward rounds will be different. So the things you're looking for in the patient will be different. If you're on a colorectal ward, for instance, you want to know whether the patient has opened their bowels, their stoma working, or they're mobilizing. Whereas on a medical ward round, if you're on the cardiology ward, you want to know whether their chest pain has resolved, or if they have congestive cardiac failure, whether their pedal edema has resolved. Yeah. So always adapt it according to the specialty you're working on. But it's just second nature. You will pick it up as you start on the job.
Hamza, a question from Michael. Can we break bad news to patients if the scans were updating the patients with a suspicious, or for example, a tumour, or is it usually done by seniors?
So I'd usually leave that to a senior. Would you agree, Nihal?
Yeah,
Yeah.
exactly. I think any serious bad news, you're not expected to deal with that as an FY1. Your senior would break the bad news to the family and the patients. It may differ in an emergency situation. So, for example, I remember during my AMU rotation, a CT scan showed that a patient had a brain tumour, and I had to contact neurosurgery urgently, which wasn't in my centre. So I had to inform the patient of the news and update him on where the progress was and that we were contacting neurosurgery with an urgent referral. So there are exceptions, but 95% of the time you won't be breaking serious bad news to patients. Khalid's just come back and he's clarified. He says he's awaiting distribution for internship. So I think I know what you mean. So you've graduated, but you're waiting a while before you get a job or before you start working. Yeah, so Hamza, do you have any tips for someone who's graduated but they're not going to start working straight away?
I mean, in terms of documentation, I'd say just you can familiarize yourself with the abbreviations, but there's not much in terms of documentation because it will be the same and you'll pick it up as you start. But in terms of medical knowledge, I would say just keep in touch with things you've learned at medical school. The Oxford Handbook, which Nihal mentioned in his previous talk about preparing for FY1, is quite good. It's quite concise about concise things you need to know whilst on the job. So it's more keeping up to date about clinical practice. In terms of documentation, the principles will stay the same. And once you learn it, it will stay with you for life. Yeah. Any
Any
advice on
advice? Okay, go ahead, Hamza.
any advice on time management on solo ward rounds and how to prioritize jobs on the jobs list? So in terms of time management on solo ward runs, when you do start off, it's quite natural to take all your time, so you'll be very thorough and precise. But then as you gain more experience, you'll you'll be quicker. But also, it's important to know before doing solo ward rounds. So your senior colleagues will tell you, "I want you to see these X number of patients today." So it's important to plan out how long you want. So how long you want to be spending. So usually a general rule of thumb is try to finish your ward round by around 12, so you can go for lunch and then come back for the jobs. So let's say it's 9 o'clock and you're starting on a medical ward round. So you have 3 hours, and your senior has said see 6 patients in that time. So then you can leave yourself around half an hour per patient. I generally leave some time at the end because some things might come up unexpectedly. But yeah, just plan your time well. Allocate like a fixed number of time per patient. Yeah. In terms of prioritizing jobs list, so I would prioritize jobs for patients who are critically unwell. So things that can actually make a difference within the next few hours if you are to do them. For instance, updating a family member of someone who's been in hospital for a week and is waiting package of care and is completely fine is not as urgent as ordering a chest x-ray for someone who might be having a lower respiratory tract infection. So in general, try to do blood tests and scans for your critically unwell patients. And if it's going to change your management plan. I don't know if there's anything else you want to add to this, Nihal.
No, I'd agree absolutely with you there. I think you learn as an FY1 which jobs are important and which can wait. So things like updating family members, discharge summaries, these can wait until a bit later on in the day.
Yeah.
Things like ordering scans are quite important. If you've got a patient who's potentially having a bleed and the HP is dropping, and you need to order some packed red cells, that's going to be number one on your priority list. Okay, so it just depends. Is the patient unwell? What needs to be done? Is the patient stable? Can things wait until later in the day? And most of your patients, generally, if the day's not going too bad, will be stable. So it's a lot easier to prioritize. But in certain situations, you've got to be sharp on the ball and prioritize the unwell patients and focus on them. Even if it takes, some unwell patients will take 2 to 3 hours out of your day sometimes, but it has to be done. Um, Another question, Hamza, from Violetta, not related to the talk, but as FY1s, do we wear smart outfits or do we have hospital scrubs? Northern Ireland FY1s usually wear their own scrubs.
So again, this will depend on your hospital and your trust. For our hospital and our trust, we're currently wearing scrubs. So this is the policy according to the infection control team. But I know in other trusts, people are wearing smart outfit. So it will depend on your trust what the policy is. Yeah.
Yeah, I think most trusts have adopted a hospital scrubs policy because of COVID and because of infection control. So most of the time you'll be wearing scrubs unless you're a senior registrar or a consultant.
Mhm.
But some hospital policies may differ. It's just about finding out what the policy is when you join.
Yeah. And again, it's important to remember to be bare below the elbow. But I'm sure you guys know this already through your experience in hospital and all. Theodora has asked, as an FY1, can you take any decision about treatment on your own? Yeah, so absolutely. As an FY1, you will have a lot of independence. Uh, and this will come more so during on-call shifts or night shifts because the consultants won't be around. You'll have maybe one or two regs if you're lucky, and 2 or 3 SHOs covering the whole hospital. So uh, a lot of the time it will be your decision about treatment plan. But that having been said, don't feel you're on your own. Support is always available. You can always run it past your registrars or your house officers. Um, but with time, like me and Nihal, like we're approaching the end of our FY1 year, you'll gain confidence. So there are things you will be able to manage independently. Yeah. But then at the start, I appreciate it can be uh, quite stressful and quite difficult, but run it past your colleagues. But absolutely, you will be making decisions about patients' care, and some of them can be life-changing decisions.
I'd agree with that absolutely. You can make decisions. Typically, if you work in district general hospitals, you'll have a bit more freedom. and responsibility than if you're working in a tertiary centre. But normally, just follow the advice of your seniors during the ward round, and you won't need to do many of the things for the patient that day. During your on-call shifts, though, you will need to make decisions for patients. You'll need to assess patients, and it's your decision whether to escalate if you think it's appropriate. Hamza, just a question from Theodora. Is the jobs list only for your use? Does it require your name and stamp on it?
Yeah, so the jobs list is only for your use. I mean, your colleagues can use it as well, but I'm sure your colleagues will have their own jobs list. No, it doesn't require your name or your stamp on it. Actually, it's best not to have your name or stamp on it. Uh, Really important not to for it to leave the hospital. Always throw it in the confidential waste bin because it has patient identifiable details on it. Keep your jobs list updated. Yeah.
Yeah, just to add to that, the jobs list is only for your use. Very rarely, some departments and some teams will have a shared jobs list. Okay, I encountered it once in medical school and never encountered it again. So it varies from department to department, but 99% of the time it's for your own use. You don't need to put your name and stamp on it. You can put your name on it if you say if it gets lost and you want someone to give it to you, but you probably won't be doing that on a day-to-day basis. Um, yeah. Any more questions, guys? No more questions? Okay. So Hamza, Michael has asked, as an extension to Theodora's question, do you pass jobs along with your notes to your colleagues at the end of your shift, or do you have to finish them all before going home?
So in terms of notes, notes will stay in the patient's folder. But in terms of jobs, you should aim to finish all your jobs by the end of your shift. But then when it's time to go home at 5, there will always be like one of your colleagues who's on call. But just bear in mind, your colleague on call is not just covering your ward. Usually your colleague on call will be covering several wards, if not the whole hospital. So uh, I would only hand over pressing jobs which haven't been done, uh, which are really important. So for instance, I wouldn't really hand over a job that wouldn't change my management plan, such as updating family member for someone who's all right. This can be done tomorrow. So most of the time, aim to finish your jobs. If you don't manage to, you can. The non-important jobs can always be done tomorrow. But if there are some really important jobs, absolutely, you need to hand it over to your colleagues on the on-call or night shift. For instance, if the results of blood tests or radiological scans, which can be life-changing, you do need to hand it over. So that can usually be done by bleeping the on-call F1, the on-call SHO to hand over the jobs. Yeah.
Yeah, I'd agree with that. You only would really hand over jobs that you haven't been able to do in the day. You should have done all your urgent jobs. If something has taken you by storm and you've been with an unwell patient for 3 hours, I'm sure your colleague will be fine if you explain this and explain why you needed to hand over some jobs to them. Don't feel like you can't hand over jobs. That's what the on-call doctor is for. But the on-call doctor is only amongst a couple of other doctors covering the whole hospital. So be kind to them. If it's not something that needs to be done overnight, it can wait till tomorrow. So only pressing things that have to occur overnight should be handed over.
Mhm.
Hamza, Theodora has another question. Do you have clear guidelines for emergency situations? So if you're an F1 on call, will you make decisions based on your knowledge or based on the trust protocols?
So as part of the F1 program, you'll be required to do the ATLS course. The ATLS course will prepare you for a lot of the emergency situations. But if you've not done your ATLS course or there are things not included in the ATLS course yet, uh, you always there's an app you can use, the Advanced Life Support app, which runs you through common emergency situations. Um, in terms of your own knowledge or trust protocol, most of the time they're the same. If it wouldn't really change much, in terms of medications you were to give. But if you had a choice, I would go according to trust protocol. Although you might appreciate that bringing up the trust protocol on the intranet might be time consuming. You might not know where it is. But if you know where it is and it's available at hand, I would absolutely go according to trust protocol. But if not, use your own knowledge. And again, run it past your seniors. Like if you have a patient who's critically unwell, you think they're having like anaphylaxis or sepsis, I would start the management and I would inform the registrar. They could also update you on the management plan, yeah, which they're more experienced with. They're more experienced with the trust protocol as well. Yeah. Anything else to add, Nihal, on that?
No, I don't. Most trusts will have protocols for emergencies. So there's a, for example, if a patient's hemorrhaging, there's a major hemorrhage protocol which you follow. If a patient's got hyperkalemia, there's a hyperkalemia protocol which you follow. If you're unsure, always, and if it's an emergency situation, you're unsure, always escalate to your seniors. Okay, it's better to be safe than sorry. Um, that's the advice I'd give for an incoming FY1. Your seniors are there to support you. They know, as an FY1, you've only been working a few weeks to a few months or whatever. So there's no stupid questions. Escalate if necessary, but there are normally clear guidelines for emergency situations, which you can access via the Trust intranet.
Can you call your
Um,
senior for hypertension, for example? Theodora has asked. Yeah, absolutely. I mean, if you've just started work, you've just started F1, and you wouldn't really be familiar with a lot of these presenting complaints. I mean, medical school does prepare us for some of this stuff, but a lot of the things are things you will pick up, which you haven't been prepared for. So yeah, I'd run it past your senior. For instance, I remember calling my SHO for a patient with hypertension at the start, but now I'm really confident in managing hypertension. So your confidence will grow, but if ever you feel you don't have the confidence, I would escalate. No question is a silly question, even if it's just being like, I've initiated this management plan and then running it past them. Would you agree, or do you want me to do anything differently? It shows you're still thinking about how to manage it, but you just want to be a safe doctor. So yeah, I would escalate if not sure.
and remember, guys, the senior doesn't necessarily have to come and see the patient. You can call them over the phone via bleep, and just discuss it with them. Most of the time, they're absolutely happy to discuss these sort of situations with you. So don't fret about that. Just a particular thing with hypertension, though. Remember, systolic BP over 180 or diastolic over 120 is a hypertensive emergency. So if they're above those parameters, I would consider all the necessary investigations and just run it past the senior as an F1. Another question from Christopher Holt. Hi, Chris. I think I went to university with you. Um, so, after you complete a job and fill in the box on your personal list, would you then go back to the main patient notes and document if it had been completed in there as well?
So this would depend on the nature of the job. For instance, if it's a really important scan, again, I keep coming back to cardiology because I did a cardiology job. But if a patient's due to go for uh, a scan, like a TAVI scan, which would help them for an operation. So these scans are really hard to organize. Um, and they will need to be discussed with a radiologist. I would go back and I would write scan has been requested. But if it's things like printing blood forms for the phlebotomist to do the next day, I wouldn't really bother. But if you think it's important, and I would go back and write it. Yeah, it won't take long. It'll just be like you go on your plan and be like, this has been requested or something like that. It would save your colleagues having to do the job again twice if they're in the next day and you're not there because there's no one to update them, no one to let them know this job has been done.
Yeah. So, just to add to that, um, updating that you've put out bloods, you don't necessarily have to do it. You can put a small tick next to it on the on the jobs list if you feel like you want to let someone know. Remember to always chase up those results. So if you've done blood tests and potassium's come back as 5.7 or something borderline, document it in the notes and say what you're going to do about it. And again, if you've requested a CT head for a patient with a suspected bleed, you don't need to document that you've requested this. You say request CT head, but you don't need to say come back and say that you've done it. Your documentation would be evidence of you doing it, and then you need to document the results. So CT head showed no acute hemorrhage, put the date, time, your name, signature, stamp it. And Saad Abdul Hamid Saad has said, what about 90/60? Is it an emergency?
So, working in hospital, you'll see lots of patients with this blood pressure 90/60. It depends. Has their blood pressure been chronically low? And anything, if it's 90 or above 90 systolic, we're not really worried. If it's dropped down slightly to like 84 and the patient's asymptomatic, you usually treat it with a fluid bolus or something and see if it improves. Initially, at the start of starting FY1, if you're not really confident, I would run it past your SHO. You wouldn't really need a reg like input. But if blood pressure is actually like plummeting, going to like I'd say 60s, 50s, then yeah, you definitely need to contact your registrar because they might need inotropic support or anything like that. But 90/60 by itself is not an emergency because even higher blood pressures, as Nihal said, systolic above 180 is a hypertension emergency. But a lot of the time working in hospitals, we've seen patients scoring for blood pressure of 150, 160 systolic, and that wouldn't really worry you. Yeah. As much as like something above 180 systolic or below 90 systolic.
Yeah, just to add to that, absolutely agree with what Hamza said. It depends on the context of the patient and what the other observations are like, what your clinical examination shows, how well do they look from the end of the bed? Do they look well? Are they sitting upright, talking, chatting with their family? All these things can point you towards a diagnosis of what's going on. Okay. Number one thing though, when you see a low blood pressure, think septic shock. Okay. Always rule out sepsis. Think about your sepsis protocol. Remember, as FY1s, this is something that you're all expected to know, and it's one of the basics. But a lot of the time, a blood pressure of 90/60 by itself, it's not an emergency. You can run it past your senior if you're unsure. You can give a fluid bolus, so 500 mils in 15 minutes. If they've got heart failure, give a little bit smaller of a bolus, so 250 mils, just to make sure they don't become overloaded. But yeah, examine the patient, look at the bloods, look at the rest of the obs, and see where your clinical examination takes you. Okay. And Saad's add to that said they've been battling a low blood pressure. They're also complaining of dry cough and chest pain, Hamza.
I think what he's coming at is uh, is the patient hemodynamically unstable. So just in isolation, a blood pressure of 90/60, yeah, that wouldn't really worry you. But if it's 90/60 and then they're having tachycardia, I guess what you mean by the dry cough side is maybe they might even be having hemoptysis, chest pain, or they're tachycardic. That would make you think, are they having a PE? Are they hemodynamically unstable? Yeah, then I would escalate. Um, Even if it's low blood pressure, tachycardic, they're having a temperature, could be sepsis as well, as Nihal said. Again, I would make the registrar available, even the registrar know. Even though at medical school we are trained to manage sepsis, it's good to know your medical registrar know about it, to be aware of it.
Just posted the feedback form again in the chat, guys. If anyone has any questions, please let us know. Otherwise, we can all head home and enjoy the evening. Any questions, guys?
think this talk will also be recorded, won't it, Nihal? It will be available on the...
Yeah, so this talk will be available on Medal via catch-up content. It'll also go to the Mind the Bleep YouTube channel. Okay, if you need to come back to it and have a look. Yeah, so don't worry if you, again, with all our future talks, it'll be on Medal, it'll be on YouTube, so don't worry if you can't attend live. Of course, if you attend live, then you can ask questions, but don't worry if you can't make it, you can watch all the webinars, they'll be recorded.
Just a reminder, we will have a talk about the deteriorating patient run by a medical registrar, so that will be quite useful for you guys. Yeah.
Does Mind the Bleep accept donations? I'm not too sure about that one. Hamza, do you know?
I'm not sure as well, sorry. Pass.
What you can do is if you want to make a donation, you can contact Mind the Bleep via Facebook or via email and get in touch with with the director of Mind the Bleep, Dr. Akash Doshi, who's actually a endocrinology registrar. I'm sure he would. I don't know if he would accept it, but it's worth having that discussion with him if you're very keen on donating. Thank you.
I think it's a non-profit organization, so
Yeah,
I don't
I
know.
think it's non-profit. Yeah.
Yeah.
So I don't think we do, but if you're very keen, you can contact Akash and see what he says. I think that's it, Hamza. I think we'll call it a day there, guys. Remember to attend our future events. The webinars are all on the Medal page and the Mind the Bleep Facebook page. Okay, we'll also post reminders to them in the FY1 Facebook groups. So keep an eye out for those, and yeah, have a nice evening, guys. Take
Thank you
care.
very much. Bye.
Bye.